For patients with metastatic pancreatic cancer who have a very high performance status, the most optimal approach is some form of combination chemotherapy. The guidelines for the National Comprehensive Cancer Network suggest that gemcitabine and cisplatin might be a very good choice for patients with hereditary forms of pancreatic cancer. And then other combinations such as gemcitabine and erlotinib or gemcitabine and capecitabine might be useful for patients with sporadic forms of pancreatic cancer. Another interesting combination is gemcitabine and nab-paclitaxel. One of the most striking studies that was reported at this Congress was the ACCORD trial. This was a trial done by a French group in which patients with high performance status and metastatic disease were randomized to single-agent gemcitabine or combination chemotherapy using 5-FU, leucovorin, irinotecan, and oxaliplatin, a regimen which they called FOLFIRINOX. The patients treated with FOLFIRINOX had a striking improvement in progression-free survival and overall median survival, with a hazard ratio of about 0.65. Now, the trial was a rather toxic combination in the sense that patients experienced a lot of grade 3 and 4 neutropenia, and also a fair amount of grade 3 and 4 fatigue. So it isn't totally clear that this regimen would be appropriate for all patients with metastatic pancreatic cancer. Another nuance of the study was that the patients were enriched for characteristics involving lesions in the body and tail of the pancreas with fewer lesions in the head of the pancreas. This meant that perhaps fewer patients had biliary stents in place, and thus the risk of neutropenia and subsequent separative cholangitis might have been less in this patient population. So it's a bit difficult to extrapolate these results to the usual patient with pancreatic cancer. I think the striking thing, though, was that these investigators followed a paradigm that allowed them to really show superiority of their combination regimen, and this regimen should be moved quickly into the adjuvant setting so that it can be tested in a patient population that is more likely to tolerate the more intensive form of chemotherapy given. But it does give us a lesson that we can proceed with more confidence into phase 3 trials, providing we pay attention to some of the principles that they used in conducting this trial. Well, now that we have some very active chemotherapy backbones, it's going to be a lot easier to look at some of the new targeted therapeutics. As you are probably aware, most of these agents in virtually any disease that they're studied aren't particularly useful as forms of monotherapy, but are often attached to a chemotherapy backbone. Some of the more interesting agents that are being looked at right now are the sonic hedgehog inhibitors, and a variety of agents that either target RAS proteins, for instance, those that adhere to the cell membrane, or target nodes that are downstream of RAS, such as MEK. So MEK inhibitors are very exciting, a variety of inhibitors that target various aspects of the RAS pathway, and the sonic hedgehog inhibitors are the ones that I'd keep my eye on. Well, I think there are some, in addition to the novel agents, there are other trials that are ongoing in phase 3 that are particularly interesting, such as gemcitabine and nab-paclitaxel, which could provide us yet another chemotherapy backbone to work on. And another trial that is already in phase 3 involves an inhibitor to EGF1R, the receptor for EGF1. That is also a very promising combination, and we should be eager to hear those results.